Welcome to your course on Tip 44, Substance Abuse Treatment for Adults in the Criminal Justice System, brought to you by allceus.com. The first thing we're going to talk about is screening and assessment. Screening is used in order to screen out people who may not need mental health or substance abuse treatment. Now, it's been identified that the majority of people who are incarcerated probably need some level of mental health or substance abuse treatment. Many people, and some studies say as high as 99% of women who are incarcerated have been victims of sexual violence. So we need to look for issues such as anxiety, depression, PTSD, bipolar disorder, and schizophrenia, in addition to substance abuse disorders. We need to assess each person's needs. What do they need in order to help them successfully reintegrate into society? Gather information and determine their eligibility and suitability for different programs offered by the prison facility. Information sources you can use include booking records, your own interview, assessment instruments that are standardized, correctional records including pre-sentence investigations, past treatment records, police reports, and drug tests. There are certain areas of concern with screening, though. You don't have a whole lot of time to meet with the person. Screening is usually like a 30-minute to an hour session. So you want to be careful about your accuracy. You also want to ensure that there's continuity and system-wide sharing of the screening information. So everybody's aware if Jim Bob has an anger management issue or if Jim Bob's bipolar, then everybody can be aware to watch out for symptoms of or signs of decompensation. It's important to rescreen and reassess periodically. Many times offenders are arrested and come in and they're under the influence of alcohol or other drugs. Likewise, some offenders come in and they have been taking psychotropic medications like they're supposed to, and when they come in they don't get those medications so they can decompensate. Either way, you may not get an accurate screening in the initial 3 to 5 days the person is there. Timing is important. You want to make sure that the screening is done early on, but you also want to ensure that the person is sober, alert, and oriented. Drug testing and detoxification needs need to be assessed. Their readiness for treatment, any history of trauma they may have had, any psychopathology, such as inability to feel empathy, any personality disorders, bipolar disorder, schizophrenia, anything that may be sort of a mitigating factor leading to their criminal behavior, and their risk for recidivism. What we're trying to do is get a picture of what sorts of resources and services can we put in place for this person in order to help them reintegrate into the community and not recidivate. Diagnosis pitfalls include stigma. Some people don't want to tell you that they hear voices and don't want to tell you that they get depressed because there's a stigma associated with it. As I said before, an inaccurate diagnosis can be made on the basis of withdrawal. When people are detoxing from stimulants, they often look very depressed. When they're detoxing from alcohol, they can become very agitated. So we need to make sure that their behavior is not otherwise due to a substance or a general medical condition. A substance abuse diagnosis that precludes mental health treatment may also be a diagnosis pitfall. We know through current research that co-occurring disorders are the expectation, not the exception. So if we just give somebody a substance abuse diagnosis and don't even consider possible mental health contributing factors or compounding factors, then we're doing the person a disservice and probably setting them up for relapse. and a substance abuse diagnosis limiting offenders' access. Some people and some facilities limit the access of persons with mental health or substance abuse issues to certain pods or certain activities. We also, in the general community, know that people with substance abuse diagnoses and especially substance abuse-related convictions have a harder time getting a job and getting access to certain programs and services. So we need to make sure that our diagnosis is accurate. Reasons for diagnosis include reimbursement. We want to make sure that the jail or the prison can be reimbursed for providing treatment to Jim Bob for the services that he needs. It supports pharmacological interventions. That is just a big old fancy way of saying it supports giving him meds to calm him down. It can be an informational factor when psychiatric concerns emerge. It may clarify the co-occurring disorders. When you look at someone who has, for example, alcohol dependence and depression, you want to look at the reciprocal relationship between the two of them, because alcohol tends to lead to feelings of depression, and depression tends to make people want to drink. So if you have a depressed person who has been abusing alcohol, who doesn't have alcohol, then they may still be depressed, which will make them want to drink. Likewise, if you have someone who's drinking and depressed, the more they drink, the more depressed they're going to become. One sort of causes or leads to the other. We need to address both concurrently. De-stigmatizing diagnosis. We want clients to understand that diagnosis is just a shorthand. It's a short way of my communicating a certain cluster of symptoms to someone else. It doesn't mean they're crazy. It doesn't mean they're nuts. It just is a way of saying, you know, this person has had changes in appetite, changes in sleep, has lost pleasure in most activities, yada, yada, yada. That takes a lot to start listing all the symptoms of depression, when you can, in shorthand, say he's got a diagnosis of major depressive disorder. Diagnosis also helps us with differential diagnosis and identifying presenting issues. So if the person has symptoms of depression, we want to make sure that it is depression and not some sort of diabetes or thyroid problem or something else. Normalize the diagnosis for people. Google famous people with, and have at your beck and call a list of famous people with some of the most common mental health disorders like depression and anxiety and bipolar. And have consumers do an all about me worksheet. Have them list all of their good qualities. They are not their disease. They are not bipolar. They have the disease of bipolar, but that does not completely define them. Screening instruments. We need to be careful about the reliability and validity. A screening instrument that was normed on 19 to 24-year-old college students very well may not be applicable and reliable for 40-year-old people in jail. So you need to make sure that the instruments you're using are normed on your population or can be used with your population. Some of the ones that you will find in the treatment improvement protocols, or the TIPs, put out by SAMHSA include the Addiction Severity Index, the Alcohol Use Subscale, the ASI Drug Use Subscale, Drug Abuse Screening Test, and the Michigan Alcoholism Screening Test. You can also use the simple screening instrument for substance abuse. All of these are relatively reliable and normed for use on adult populations. The Addiction Severity Index can be reproduced. It's done in a structured interview format and examines functioning with regard to drug and alcohol use, relationships, employment, legal involvement, and physical and mental health. Substance abuse, it looks at the history of the substance abuse, whether it has gotten worse over time, stayed the same, polysubstance, motivation for substance use, the severity and frequency of use. Are they using occasionally on the weekends, or do they get money on the first of the month and by the second it's gone? It assesses detoxification needs and treatment history. What's worked in the past? What hasn't worked? We don't want to keep beating our heads into a wall. If the person's gone through treatment and it hasn't worked, we want to look at why it didn't work. But if it's clear that this is not a modality that's appropriate for that person, don't keep doing it. Then we look at criminal involvement and assess criminogenic thinking, the stinking thinking, the attitudes of entitlement and fairness and other thought patterns that are characteristic of persons in the criminal justice system. We want to look at their offenses. What have they done? Is it something that is a reaction? Are most of their behaviors geared around substances, getting substances, things they do when they're high on substances? Or do they have a relatively stable pattern of offenses that are not progressive? They keep getting busted for petty theft, petty theft, petty theft, petty theft. Well, that can mean they're just doing petty theft to pay their drug habit. It can also mean we need to assess them for fetal alcohol spectrum disorders. The apple don't fall too far from the tree. And if mom was drinking while she was pregnant with Junior, then Junior may have some difficulties with impulse control, learning from consequences, and tending to follow people too easily. So I always encourage you to look for signs of fetal alcohol spectrum disordered behavior in consumers, especially ones that are involved in substance abuse treatment or the criminal justice system. Because if Jim Bob's abusing substances, chances are somebody in his family may have, and mom may be the one that was drinking while she was pregnant. We want to look at the options for probation, any success they've had in diversionary programs, and any diagnosis that they've had of a personality disorder, especially, of course, narcissistic or antisocial personality. I do want to comment, though, before I change slides, that many of the symptoms of personality disorders are also behaviors or symptoms you see in people who are very entrenched in addictive behavior patterns. So if the person has some substance use abuse, I would encourage you to defer the diagnosis of the personality disorder until they've actually gotten clean and sober, and then decide whether or not they've got a personality disorder or that was a remnant of the substance abuse. We look at health in relation to their level of intoxication, infectious diseases, pregnancy, their general health, and acute conditions, such as whether they've got a broken arm or they had a concussion, or maybe they've got HIV or something else that needs to be taken care of. Then we assess mental health. Are they suicidal or homicidal? Have they ever had a mental health diagnosis? Has anyone in their family ever had a mental health diagnosis? And again, like substance abuse, what's their treatment history? What's worked? What hasn't? Have they even tried anything? What are their current presenting acute symptoms? And what medications, if any, are they currently on? Special considerations when dealing with anybody, not just criminal justice populations, include their educational level, their reading and literacy level, language and cultural barriers, physical or developmental disabilities, learning or cognitive disabilities, housing, dependence and family issues, and history of abuse, either being the victim or the perpetrator. It's important when you put somebody in a treatment program or start a treatment process with people that you provide the information and you provide a setting that is conducive to their special considerations and needs. If you have someone who is extremely dyslexic and can't read and write and has some developmental delays, you're going to have to provide services in a much different way than you are for someone who is a college graduate who is developmentally on task. Triage and placement. You want to look at the continuum of services, including pre-treatment and detoxification, outpatient services, and inpatient. Now, we always say we want to treat people at the least restrictive level of care. So if people can stay clean and sober and out of jail in outpatient, then that's where they need to be. But if they can't, then they may need to be inpatient for a while until we get them stabilized and their brain chemistry starts returning to where it's supposed to be. Key staff preparations, including make sure you have a treatment resource database, especially for programs that cater A, to the criminal justice populations, and B, cater to people with co-occurring disorders. Know the eligibility and suitability criteria, know how to make the referral process, and try to get memorandums of understanding, or MOUs, in place with the agency prior to working with consumers. That way you don't have to walk this weird HIPAA line about sharing information. Now make sure it's clear in the MOU that you are going to share information and you've got the business associate agreement and everything before you go on doing it. But the MOUs do establish a formal relationship between agencies to provide a level of continuity of care. Placement strategies include targeting offenders with a moderate to high risk of recidivism by looking at their criminal history, poor employment history, poor supportive environment, homelessness, and antisocial traits. And again, this is not a personality disorder necessarily. This could be substance issues that lead to impulsivity, lack of empathy, anger issues, and a sense of entitlement. In substance abuse, people tend to be impulsive because they want their drug. They've got no coping skills. They lack empathy because they're overwhelmed. They don't feel much of anything anymore. They just want their drug. Anger issues are pretty self-explanatory. And that sense of entitlement is often a bunch of bluster that they throw up in order to keep you from really seeing who they are and what their problems are. So again, before we give a personality disorder diagnosis, make sure that we do effective differential diagnosis. Moderate to severe substance abuse problems can be identified with substance dependence, substance-related arrests, a history of substance abuse with or without treatment, and positive drug tests. Moderate to severe mental health issues can be identified by a history or current suicidal or violent behaviors, acute symptoms of bipolar, depression, anxiety, schizophrenia, any of the above, and then some, cognitive impairments such as problems with concentrating or problem solving or inability to, quote, pass a mental status exam, and social impairment, including poor interpersonal skills and a low frustration tolerance. We want to assess the person's readiness for change based on their perceived severity of their problems. Do you really have a problem? If so, how bad is it? We want to help them increase their motivation. And to do so, I would recommend looking at tip 35. and you can use the Socrates, which is the Stages of Change, Readiness, and Treatment Eagerness Scale, in order to help identify the offender's level of motivation. You also want to look for prior evidence of attempts to improve and get an idea of their perceived importance of treatment. Implementing treatment includes involving the person in treatment planning. Don't write the treatment plan and give it to them. Teach them how to identify and set goals and break larger goals down into smaller goals. Teach a man to fish. Don't give him a fish. Use motivational interviewing to help increase the offender's level of motivation for change in one or more areas of his life. And he may not be ready to work on the substance abuse yet. He may just want the depression to go away. Or he may want to deal with his anger management, or whatever. Meet the offender where they're at, emotionally, cognitively, socially, and interpersonally. Coordinate with the team. Provide updates as the status changes. And ensure that the person has community-based linkages when they are released. That way they can effectively and seamlessly reintegrate with the community. Provide outreach and low-intensity interventions to all offenders, especially during when they come into jail, during their daily activities, and at exit and reentry. Always provide those motivational interviewing techniques. Always provide encouragement, self-esteem building, coping skills, modeling, etc. throughout the daily interactions. And make sure they have a plan at exit and reentry for reintegration into the community. General criminal justice treatment issues include components of criminality. We need to understand that most people, especially career criminals, have a criminal code and a set of irrational or dysfunctional thought patterns characterized as criminal thinking. Manipulation and power and control are huge in this population. So getting people to be real, so to speak, is always a challenge. Getting people to snitch on other people, probably not even going to happen in jail. And it's questionable whether it's going to happen very often in a treatment center. You need to be aware of this. The other thing that's big in criminal thinking is respect. And that's one of the values that we use in our treatment center to help people feel a little bit better about, quote, snitching on some of their housemates. Because by bringing drugs into the facility, they're showing a lack of respect to the people who are trying to do the next right thing. Criminal thinking is a learned behavior. In order to help people break this pattern, we need to help them recognize thinking errors and its impact on their behavior. This can be done through cognitive behavioral therapy and staff and peer confrontation. Many people who have high substance abuse issues and low mental health issues, that means their depression is sort of secondary, it's not extreme, do well in therapeutic communities because the structure and the confrontation really supports changing thinking patterns. The criminal code includes refusal to cooperate with authority, refusal to confront negative behavior. Participation in treatment is viewed as weakness, and the snitch syndrome. They will often use techniques to manipulate us, including throwing focus. That means pointing out what somebody else is doing or what you're doing wrong or what the system has done them wrong in order to keep you from focusing on them. Team splitting and demeaning others. It's important to address manipulation when you see it. Identify primary thinking errors. Instruct the client to begin self-monitoring and journaling. And provide regular feedback through treatment group peers as well as through staff meetings with the client. Other behaviors that we see in this criminal thinking is excuse making, blaming, justifying. I think, therefore it is. I think I am all-powerful, therefore I am. Lying, either by commission or omission, which means they either tell you an out-and-out lie or they lie by failing to tell you certain parts of the truth. Making fools of or pulling the wool over your eyes, or building you up to bring you down. Now you can think about all of these behaviors if you work in substance abuse right now, and you can identify a lot of these behaviors in the people that go through your center, even if they don't have a history of repeated arrests and repeated jail sentences. A lot of this is very, very similar to addictive behavior. Assuming. Well, we know what they say about assuming. This notion that I'm unique and the rules don't apply to me. Ingratiating themselves to you. Doing what they think you want and sucking up to you all the time. Demonstrating fragmented personality behaviors, just being inconsistent. One minute they're really happy and sweet. The next minute they are a big jerk. Sometimes they're narcissistic. Sometimes they're histrionic. They're just kind of all over the place. And a lot of that is the chameleon-esque, where they're trying to manipulate multiple people at multiple times. Minimizing or exaggerating, generally in ways that make themselves look good. Being vague or non-committal in answers or responses or treatment work. A lot of the treatment work I see out of people, especially who are in pre-contemplation, is very vague. Lots of anger, displays of anger and puffing up, and power plays. They will jump right over you and generally right over your supervisor and go to your supervisor's supervisor whenever they have a problem. They'll threaten to sue you. They'll threaten this and they'll threaten that. And the anger and power plays are about trying to get you to back away because you've gotten too close or you represent a threat in some way to their status or their sense of security. Victim playing. We've all run into consumers who tell us, and some of them may believe, that the stuff was planted on them. It's not their fault. They're innocent. They're a victim of everything. Or maybe they're a victim because they had poor parenting and they didn't have all the benefits of everything. They can be unaware of others' boundaries, and they can switch back and forth in their image of themselves as either being the cowboy with the 10-gallon hat or the victim, depending on what suits them best at the moment. When addressing anger and hostility in this population, we want to help them identify the feelings that led to the anger and hostility and the thinking patterns. Understand where the feeling is coming from. REBT is extremely helpful with a lot of adults, and especially dealing with angers, to identify the dysfunctional beliefs that lead to destructive behaviors. It's important to identify the goals the anger is serving. The first time you tell somebody that, they're going to look at you like you got 3 heads. Every behavior serves a goal. Anger gives people power. It pushes other people away. It makes people feel safe. There's a lot of different benefits that can come of anger. So the consumer needs to identify What was the benefit to acting out? Identify goals the anger is undermining. If you want to get out of here with, extra time off for good behavior, then you can't be beating up your cellmate. If you want to get out of here with extra time off for good behavior, you can't be cussing out the guards every day. So let's look at what goals the person wants to achieve, not your goals, but the client's goals, and identify ways that anger and outbursts are undermining them. And help them work toward taking the longer view, good orderly direction. 6 months, a year, 5 years from now, what do you want to be different? What do you want to be doing? Barriers to effective treatment include doing assessments and then making inaccurate placements. A lot of this is due to poor staff training or staff transitions, and over-reliance on institutional sanctions versus peers pressure. A lot of times, those of us who haven't been in and out of jail think that institutional sanctions would be pretty rough. But people who've been in the system, they're like, I'll do my 90 days, it's not a big deal. Versus peer pressure, which can be a lot more motivating because it's all about respect and power and hierarchy. Aftercare availability and compliance is also important. Just like you can't take somebody from a residential facility, have them in there 24/7 for 2 months, and then, throw them out the door with their stuff and say, good luck. You can't do that to the person who's been in jail either. You can't take somebody from that structured of an environment and turn them loose and expect them to be able to just automatically organize and integrate. Aftercare is crucial. Even if it's aftercare by going to 12-step meetings, 90 or 180 meetings in 90 days. Coercion is often a barrier to effective treatment. If you tell them that they have to do something, that's the fastest way to get them not to do it. It's important to help the consumer see how this meets their goals. Sentencing alternatives include pretrial diversion, supervision in lieu of detention, and treatment in lieu of prosecution. It's important after doing an assessment to maintain a client's confidentiality, avoid discussing the criminal case, make sure you presume the client is innocent before trial, be realistic about what responsibilities you expect the person to take on, avoid inadvertently penalizing someone for admitting that they've been in treatment, and try to focus on recovery rather than focus on just beating the case. There are 10 components to drug courts. They integrate treatment services with the justice system. They use a non-adversarial approach to promote public safety while protecting participants' due process. They identify issues early and make prompt placements into effective treatment programs. It helps people access treatment for co-occurring disorders. They monitor abstinence through drug testing. They use a coordinated strategy that governs responses to compliance. There's a set disciplinary action for each inappropriate behavior. There's ongoing judicial interaction with the participant. Many times I've seen in drug courts this can actually become a positive interaction. As the person makes more right choices, they develop less of an adversarial relationship with the magistrate or the judge. Drug courts use monitoring and evaluating goal achievement in order to phase people up. They ensure that all members of the team have continuing interdisciplinary education, And they forge partnerships for local support and program effectiveness, including partnering with public agencies and community-based organizations to assist persons in transitioning back into the community. Task programs bridge treatment providers and the criminal justice system. They provide a range of services, including screening and assessment, referral to community-based services, monitoring of treatment, case management, and court liaison activities. The task assessor will also often go into the jail prior to the person's release and perform the assessment and make the recommendations so they can transition directly from jail to treatment. Interventions. Brief cognitive behavioral therapy as detailed in Tip 34. Motivational interviewing as detailed in Tip 35. Behavioral contracts, as we've all probably used. Behavioral contracts need to identify specific behaviors and specific expectations that the person needs to address. Phased treatment, so after you do a certain set of activities and stay clean for a certain period of time, you apply for phase up, which gives you more privileges, different assignments, and generally some more freedom. Substance abuse education, detoxification, day reporting programs, and drug testing. Some or all of these treatments can be used effectively with any individual. We can provide video feedback to people regarding their criminal thinking in order to help them see what they're doing, assess what they're doing, and change their habits. We can provide coping skills training, relapse prevention tools, strengths building, and I don't mean going to the gym. I mean helping people identify their inherent personal strengths, develop a certain sense of personal pride for those, and capitalize on them. And communication skills enhancement. In addition to all the things we can empower the person to do and all the skills and tools we can provide, we can't expect the person to do well if they go out and they're in isolation. We want to ensure there's a wide array of wraparound services, including job readiness programs, liaison with employers that will be willing to hire people with criminal records, vocational training, literacy assessments and referrals, anger management, HIV education, testing, and counseling, assistance in accessing public assistance, assistance finding and getting hooked up with self-help programs, there are many other wraparound services that were not covered in that slide, such as transportation, child care, access to medical services, and prescriptions. We can't overlook the biopsychosocial component of treatment. In jail, most treatment is involuntary, and it's constrained by scheduling issues. There are gang affiliations that may prevent certain people from certain pods being in the same therapy group together. There are issues of confidentiality, trauma, and hopelessness that have to be addressed. In community supervision, it's important to make sure there's an array of services available, ranging from the residential therapeutic community to intensive outpatient, halfway houses, and day reporting programs. Women in jail may have some issues that are unique to them. such as mental health issues, abuse history, HIV positive results, poorer employment histories than women of their same age, child custody issues, and a lower educational level. Now, this was what was stated in the book. I would be willing to say that most of these issues also apply to men. Elderly persons that are incarcerated have often been in and out of the system. Their prison rules and structure are the norm, and they often have developmental milestones which are completely absent. This has been referred to as disculturation. They've been out of the community for so long that they don't know the rules and norms and developmental expectations of average society. Engage them by having them help others. Special issues which may be encountered by elderly prisoners include increased health problems, slow responses to directions, physical issues presenting as mental health problems, and a lack of assertiveness which lets them slip through the cracks. In summary, criminal behavior is a unique set of learned behaviors. It's important for us to recognize that there are drawbacks and benefits to giving up criminality. In order to work with the client, we need to meet them where they're at and develop an alliance with clear boundaries and rules so we can identify biopsychosocial issues which influence treatment and recovery: housing, food, medication, safety, clothing, employment, transportation. There are a lot of things that the person needs when they're released from jail in order to assure them a seamless transition into the community.